as much as folks love to say, I want the government out of my healthcare, I just literally crack up every time I hear that, because we already do have a single payer in America, and that's Medicare.
From Offscript Media, I am Matthew Zachary, and this is Out of Patience. On today's show, John Gorman, founder of the Gorman Health Group, member of the board of directors of Henry Ford Health System's Health Alliance Plan, and the chairman at Nightingale Partners, which, to paraphrase, makes things suck a whole lot less for underserved and economically disadvantaged communities by focusing on racial disparities in healthcare. And that's the gist of today's show. He's got 30 years of experience in public service. He's given so much to our country, and he's got a genuinely unique perch on which to sit atop. And his advocacy efforts have spawned almost a dozen entrepreneurial ventures in government health programs that actually help people. What a novel idea. Note of caution to our listeners. John has very strong opinions, and this episode does touch on some very pointed and timely political issues, maybe with a sprinkling of COVID thrown in there for shits and giggles. So buckle up, gird your loins, you have been warned, enjoy the show. John, thank you so much for coming on Out of Patience. It's a real honor to get to know you and to see your storied career as a public servant. And you must have a credible perspective on everything you've witnessed over the last 20 years, 30 years, 40 years. I wanted to start out with an intentional softball question, which may have an intentional hardball answer, if you would.
Please. It's a great pleasure to be here. Thank you for having me.
One of your quotes, I think it's on LinkedIn or your website, it's like, you have strong opinions, which is good, and you rely on evidence. What's that like to rely on evidence?
You mean these days when there's a war on science going on?
Yeah.
I rely on evidence as generally my blanket defense for Trumpists and everybody else that is, following the president's line right off the cliff like a bunch of lemmings that just don't want to believe in science, and that we can have evidence-based interventions for just about any sort of healthcare condition, especially COVID-19, and they're all choosing to ignore it.
I think that's a fair answer.
That's a little bit of political shade there in my profile.
No, and well deserved. I mean, I've always worked in this. I'm not a scientist, of course, but I'm a very logical person, I'd like to believe. And you really want to be conservative and identify risk. And Fauci was really phenomenal. I forget which show he was just on, but he talked about how it's okay for science to acknowledge it makes mistakes because they don't have the evidence to back up the data. They make suppositions based on risk. That's a lot of syllables, that's a lot of intellect, but at the end of the day, that is a phenomenal way to just ensure that you're ideally doing things as best as possible.
Absolutely. And it's not lost on me that just this morning, Trump's chief of communications, Dan Scavino, posted a disgusting cartoon on Facebook equating Dr. Fauci with a faucet of false information.
Yeah, this is America.
In a nutshell.
Hashtag
this is
2020.
America in 2020. Yeah, exactly.
So I want to get started with a couple of one-on-ones because, again, you have an incredible history in the background working for the government, and you were working for CMS before it was CMS, which is Medicaid Services, in the 90s. Can you give us a 101 just for the average listener that, this is syllables we hear in the ether. We don't know what it means until we need it. Healthcare is a supply-only economy. What is Medicare and what is Medicare Advantage?
Sure. Well, Medicare is our program of health insurance for elderly and disabled Americans that started in 1965 when President Johnson signed the Medicare and Medicaid amendments to the Social Security Act. And the program enrolls over 70 million people today. It's generally known for its fee-for-service payment approach for the majority of people who are enrolled in it. But that's where Medicare Advantage comes in. Now, Medicare Advantage is the private option in Medicare, where the program contracts with private health insurance companies to administer the Medicare benefit on the agency's behalf. And in doing so, they are paid completely differently, obviously, than fee-for-service doctors or hospitals are in traditional Medicare. As a result, Medicare Advantage plans offer a wide range of benefits that are not available in traditional Medicare, and has historically done a much, much better job in both quality of care and member satisfaction than the traditional Medicare program has. And now we're on track for 40% of beneficiaries in the program within the next year or two.
Okay, so basically, Medicare is the basic plan, like the freemium plan, and Medicare Advantage is you buy into like the silver package and you get better benefits.
Not quite, but close. In traditional fee-for-service Medicare, you can go to basically any provider that you want, but you're going to pay, or you're going to be responsible for 20% of the costs of any encounter with a provider. And that's why you have what we call Medigap, or Medicare supplemental insurance, which is designed to plug the holes in traditional Medicare coverage and pay for a lot of that cost sharing that's expected in traditional Medicare's design. Medicare Advantage is a whole other thing where it's administered, as I said, by private insurance companies, but it's much, much more heavily regulated than the traditional Medicare program is, in that they have very, very specific quality measures. There's a body of about 50 quality measures that the plans are held to. They're paid entirely differently, as I mentioned earlier, than you see doctors or hospitals paid in traditional Medicare. I suppose the one big difference that we should be aware of is that Medicare Advantage historically has enrolled a much higher proportion of lower income beneficiaries, and especially racial and ethnic minorities are drawn to the program because, in effect, in Medicare Advantage, you are trading access to providers in order to get cheaper coverage. So you're going to go into an HMO or a PPO, and you generally are incentivized to stay within network with these types of products to get maximum benefits and maximum coverage. If you go outside that network, then you can be 100% responsible for the costs of that visit or that encounter. So you get, in some respects, less access to care in Medicare Advantage, but in return, you get a big package of supplemental benefits like vision, hearing, dental, gym memberships, and things of that sort that many, many millions of beneficiaries really love the program for.
I think I understand that now. Thank you very much for that
Okay,
kindergarten
sure.
explanation.
No, not at all.
I mean, your focus is really on underserved communities and racial disparities in healthcare. Have you seen economically disadvantaged communities benefit from Medicare Advantage 101 versus those who may have to just be on regular Medicare?
Well, I mean, absolutely. Now, having said all that, Medicare Advantage has had, for the last 5 years that we've been tracking it, a consistent problem in racial and ethnic disparities in care. This was the 5th consecutive year, as I mentioned, where we saw Black and Latino beneficiaries with lower quality ratings of care that they're receiving from the plans than they saw from white beneficiaries. And I think that's just really a reflection of the incredible inequities that are built into the American health system, and that really have been laid bare in this whole pandemic that we're all suffering through right now. This is really where you see the inequality and, in effect, the systemic racism that really defines our healthcare system, when we see Latino and Black Americans dying at 3 to 4 times the rate of their population, of their representation in the population. That tells you unequivocally that, there are rampant racial disparities in our healthcare system, and that is also reflected in Medicare Advantage and some of the quality measures that the program is known for. So, for instance, you see far lower rates of assessing body mass index, or far lower rates of medication adherence among Black and Latino beneficiaries than you do among white beneficiaries. And a lot of that just has to do with, just sort of intrinsic racism that we see among healthcare providers.
Yeah, my work in advocacy over the past couple of years in young adult cancer really yielded these, I say the ebb tide. When the tide goes out, you really see all the crap on the beach. I've been saying that for years. And on nearly every time on the show when I talk to people, and if the same woman in her 30s gets the same breast cancer and is treated at the same clinic, she's more likely to die or have metastatic disease if they're Black. It's like the Walking While Black documentary. It's like cancer while Black is an automatic predisposition for a poor outcome. Is there anything that has been concretely attributable to that outside? I mean, I'm not arguing genetics or distrust of the system. How would institutional racism or unconscious disparities play into that?
Well, you see it in everything from the rates in which pain medications are administered to Black women during and after childbirth, to how we treat Black and Latino cancer patients, up and down the spectrum of virtually every measurement that we have. We see that our healthcare system does a pretty lousy job of caring for especially lower income racial and ethnic minorities. And that is, obviously been what's defined our experience with COVID in America. And part of the reason why we're seeing such incredibly high mortality rates in these two segments of the population is, one, the fact that there just aren't nearly enough healthcare providers in traditionally lower income Black and Latino communities. They're what we call, and there's a federal designation for this that we rely on, called a medically underserved area, that measures the number of providers relative to the population. And in virtually every major urban area that we have, you see incredible rates of medical underservice, of woefully inadequate numbers of primary care physicians and their extenders in particular. And generally speaking, a pretty horrible undercount of minority physicians serving populations that look like them. That's generally where you get the best results in minority populations, especially among the elderly, is that when they're being served by Black or Latino doctors who really can exhibit some cultural competency in the way that they're cared for, that's where we generally tend to see the best results in the rooting out and reduction of disparities in care. But, we do very little in this country to incentivize doctors to practice and remain in medically underserved areas. We have this wonderful program in the country that almost nobody's ever heard of called the National Health Service Corps, which is run out of our federal Department of Health and Human Services, which basically says to doctors, if you practice in these medically underserved areas, like in a federally qualified health center, or a primary care clinic, for instance, and you stay there for 4 to 5 years, we'll pay off all your med school debt. And that's been an incredibly powerful tool to lure healthcare providers to the communities that need them the most. It's just been woefully and tragically underfunded since its inception.
What do you attribute that to? It sounds, on the surface, it sounds, of course, I'm no expert in police brutality. I'm just an armchair listening to the news, but I'm getting a sense that when policing communities have a higher percentage of African-American police, those neighborhoods are better. I don't know what better means with the white guy voice I'm using, but you're articulating that has a very similar impact if an African-American community is treated with African-American doctors. And yet there's an incentive to do so and it's not working.
Well, it's working. It's just been so underfunded and it's generally so small that it can't have the impact that it was originally envisioned to have.
But if it improves a health outcome, wouldn't that incentivize the system to look at cost benefit and accelerate the value of that?
Of course. And, that's certainly the case with the federally qualified health center program itself. The community health center program also came out of the same law that launched Medicare and Medicaid. And today we have thousands of these federally funded primary care clinics, and it's still not even close to being enough to meeting the need. It really is a microcosm of our complete and utter failure to invest in and support our public health infrastructure more generally. I mean, just look at what's going on right now with COVID, with CDC, with, the completely botched response to this virus, and the fact that we are letting both providers and bug hunters at both the federal, state, and local levels to go without, desperately needed equipment, PPE. We haven't even really begun contact tracing in any real measure compared to other industrialized countries. I mean, this has just been a complete failure of the federal government in every respect. And it really has shown that our decades of undermining and cutting funding for public health generally has really contributed to the jam that we're in right now.
Back with our guests after the break.
Has your chronic illness made it difficult to continue working in the traditional way? Want to learn how to find and create flexible remote work that both accommodates your chronic illness and generates an income? Join the Patients Getting Paid membership, a community of chronicpreneurs where people just like you find workshops and trainings, weekly updated condition-specific gigs, twice monthly coaching calls, co-workings, accountability, and the kindest community to support you on your path to make money while working from anywhere and taking good care of yourself. Learn more or join us at patientsgettingpaid.com.
So, John, shifting gears, I mean, it's tangential and adjacent to everything we're talking about is, you've been working for the government for many, many years. I love you have a phenomenal quote that sounds like it could only come from you. The biggest impediment to more holistic care for complex, vulnerable patients has always been money. You were appointed by Clinton to basically be the first assistant to the director of healthcare. I'm reading this verbatim, financing at HFCA, which is now CMS. You have a perspective, a crow's nest, looking out at profit versus purpose and the entire economy of healthcare. Looking in your rearview mirror, can you see pros and cons? Can you point to one or two things that, oh my God, we actually did something right?
Well, I mean, sure. I mean, Medicare Advantage and Medicaid, which CMS, or my former agency, the Healthcare Financing Administration, runs, are two of the most resounding successes the government's ever engaged in. Both programs have their share of problems. But when you consider the fact that between those two programs, you're talking the biggest insurer on the planet, that's a very big deal, and that they play a really fundamental role in our healthcare system, both in financing and delivery of healthcare. Now, Medicare Advantage has worked at times better than others. Generally speaking, the program works really, really well in terms of accomplishing its goals and objectives. To be blunt, when Democrats are in office and they regulate the hell out of the program. I mean, the whole construct of Medicare Advantage, which we in effect built during the Clinton administration as the program was exploding in the early 90s, really does provide the perfect framework for imposing all sorts of quality measures and expectations of treatment and provider network adequacy and the like, that really do provide a framework that, if we wanted to, could really provide universal coverage. I mean, we saw a lot in the Democrats' candidates debates earlier about Medicare for all. And Medicare for all is just a really dumb idea from a guy who used to run the program. Just doing traditional fee-for-service Medicare for all for everybody in America would literally set the country back 40 years in terms of the way that we pay for and administer healthcare. What is actually possible and what could really work to provide a uniquely American approach to universal coverage would be Medicare for all who want it. It was really the platform of Kamala Harris and Pete Buttigieg during the primaries. But that's actually a reasonably viable approach. You're never going to get Medicare for all through the Senate, no matter if Democrats retake the Senate or not. Medicare Advantage, however, is literally one of the most popular programs in Congress, and it's got every year hundreds of congressmen and state and senators that sign an annual letter of support for the program and to keep its rates up. And that I actually really think is the blueprint for getting us to about as close to universal coverage as possible. So, I mean, that has worked unequivocally. Medicaid, where the hell would we be in the middle of this pandemic without Medicaid? And thank God for Obamacare, because the Medicaid expansion has done more to pick up the millions of Americans who've lost their employer-based job coverage during this recession. And now we're even really starting to see proposals in Congress to automatically enroll people who are losing employer-sponsored coverage into Medicaid. And for the first time, we're really starting to see red states like Oklahoma. I mean, God, just last week, Oklahoma expanded Medicaid. That's about as red as a red state gets.
That wind is sweeping down the plain, John.
Exactly. And it's like, I think people are even, the Trumpiest, maggotiest red state governors are really beginning to realize that, man, we're killing ourselves by not taking this Medicaid expansion. I mean, the feds are going to pay full freight on this thing for the first 10 years. And we're basically paying for it anyway through our tax dollars going to blue states that already expanded Medicaid. So we might as well do it. And as a result, we've seen millions of new enrollees in Medicaid, and a crisis made less worse by millions of folks losing employer-sponsored coverage and then getting rapidly picked up by Medicaid instead if they're eligible. So, I really do think, as much as folks love to say, I want the government out of my health care, folks, I just literally crack up every time I hear that, because we already do have a single payer in America, and that's Medicare. And we already do have a program that covers over 72 million people, and that's Medicaid, and doing a pretty fine job of it in most states.
I wanted to also touch on what my world has been, which is the role of the consumer/patient advocate, the modern day Ralph Naders, who've really pushed for consumer influence and legislative influence and supported lobbyists like yourself to get things done based on the pressure of the vote. Would you look back over the last 30 years and opine somewhat that the power of the consumer as an advocate and the organizational nature of mobilizing basically Americans to push forward for things has moved the needle on X, Y, or Z?
It has in some respects, but not in others. I mean, traditionally, you see pretty generally weak advocacy around Medicaid because of the populations it serves. It serves an extremely low-income population and disabled, and then very low-income elderly people who are generally not politically active, if for no other reason than the fact that a lot of the folks on Medicaid are working multiple jobs and just don't have the time to advocate for themselves. So that's on one hand. On the other hand, you have seen in Medicare Advantage incredibly powerful grassroots advocacy. And in fact, you see in Medicare Advantage a bit of what we call here in Washington astroturfing, which is when we put together sort of fake consumer organizations that will advocate for a program or a policy. I mean, you see drug companies do this all the time around certain therapeutic classes, where they will get, real patients to come together to advocate for something that's basically a pretty nakedly profiteering drug company kind of strategy. But, for instance, then you look at a group like the Better Medicare Alliance, which was basically put together to lobby for Medicare Advantage. And that organization has been incredibly influential and really commands a fair degree of influence here in Washington.
The word intervention can be misconstrued quite often. And, it was also like we talk about drug addiction and Dr. Drew, like I grew up in the 90s, like this is all about MTV and interventions. Today, it means something very, very different because it could ideally have proven the model like peer-to-peer and access to care and community cancer centers getting more money. You can actually save the system a lot and provide so much cost benefit and productivity gains and back to work and less visits at the hospital. We've quantified this for so many years now. What are the interventions that you've seen? I keep going back to the National Health Service Corps. That sounds like a phenomenal way to create something, but it's underfunded. From the word intervention as a semantic, as syllables, how do you interpret that today in modern healthcare?
Well, an intervention can be virtually anything. In the world I live in now, an intervention is a program that you stand up to counter the effects of social determinants of health. And that's sort of my new passion and focus with, my retirement project in Nightingale Partners, which is our fund that invests in big social determinant of health interventions. I mean, the science is, and the research is very, very clear that by standing up programs to address social determinants of health, and let's just face it, social determinants of health are just four fancy words for poverty.
Yeah.
Okay. And all the research shows us that 60 to 80% of all healthcare expenditures in America can be attributed to social determinants of health. Where you live, what you eat, what you drink, what you breathe, who you live with, condition of the housing that you're in, how much education you got or didn't get, what your income level is. All of those things are social determinants. And the research further shows us that when you stand up a program and you try to intervene with these social determinants, that you can generate incredible savings to the healthcare system just by doing some basic human things. So let me give you the extreme example, my favorite example. A couple of years ago, Geisinger Health System in Pennsylvania, one of the most celebrated rural health systems in our country, found that they were spending $300,000 per patient per year on their uncontrolled elderly diabetics. Okay, so they started a medically appropriate meal delivery service for 1,000 of them. And within 14 months, they dropped the average cost of care for these patients to $48,000. And so net of the cost of the meals prepared and delivered, they saved $192,000 per patient per year just by feeding people. Okay, that for me as an investor now is as good as it gets. That was a 35x ROI. And that's what this stuff is all about. We see study after study that shows that housing homeless patients ends up in an 80% reduction in their healthcare costs. We find that providing seniors and low-income mothers and disabled people a community health worker to help them better navigate the system, get all of the social welfare benefits that they're entitled to, and just simple things like getting guidance on how to eat right and take their medications properly. A community health worker will save, on average, $2,500 per patient per year just by having somebody to serve as an advocate and a guide for really vulnerable and complex patients.
So surely with that incredible perspective and the fact that there is evidence that some of these things work, I'm optimistic, which is odd for me because I'm a cockeyed pessimist, but the New Yorker in me is looking forward to seeing how these things might actually do something. John Gorman, founder of the Gorman Health Group, member of the board of directors of Henry Ford Health System's Health Alliance Plan, chairman at Nightingale Partners, which invests in social determinants of health. John, you're a warrior, and I want to thank you for making things suck a whole lot less for the undeserved people who deserve better.
My pleasure. Thank you so much for having me. It was great to be here.
That's all for today, folks. If you like the show, be sure to subscribe, leave a review, follow us on social, and tell all your friends to listen. Out of Patience with Matthew Zachary is a product of Offscript Media. Our executive producer is Matthew Zachary. Our senior producers are Jen Horangeff and Andrew McDowell. Darren Tunn is our production intern. It is recorded, mixed, and edited by Matthew Zachary. Our theme music is by the Mike Van Allen Quintet and by Mara. For advertising and media inquiries, email media@offscript.com. Hit us up at contact@offscript.com to share comments, feedback, and make guest recommendations. For more information, visit offscript.com.